Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations that you picked up on the way in, and if you could give the CME committee ideas in regards to future topics or future speakers, we'd be quite appreciative. Today, I have the pleasure of introducing Dr. Edward Loftus. Dr. Loftus is a gastroenterologist. He did his fellowship at the Mayo Clinic, where he has stayed, and he currently is a professor in medicine at the Mayo Clinic and also a consultant in the Division of Gastroenterology and Hepatology. He is an authority on inflammatory bowel disease. He's authored multiple textbook chapters and also has had hundreds of papers published in the peer-reviewed journals pertaining to inflammatory bowel disease, and he's also been singled out for his excellence as a teacher at the Mayo Clinic, and so we're quite pleased that he could join us today here in Ames to provide us with an update on advances in inflammatory bowel disease. So please join me in welcoming Dr. Loftus.
Thanks. Well, thank you, Dr. Hallberg, and thanks for coming today. I know this is a busy time of year, the summer months, but I appreciate your attendance. So what I hope to do today is provide you with an overview of how currently we're managing people with ulcerative colitis and Crohn's disease, how there have been some changes in our treatment approaches, update you on some of the new medications, and also how we're working in some of the newer tools such as drug levels into our practice. So again, existing treatment paradigms, but then also how things have changed, where we're trying to risk stratify patients, treat earlier in the course of disease, using objective measures of inflammation to make treatment decisions, and then following up with more objective measures to see that we're actually having an impact in decreasing inflammation, and then therapeutic drug monitoring. So Crohn's disease and ulcerative colitis are separate but related conditions. Ulcerative colitis, by definition, affects the large intestine only, whereas Crohn's disease can cause inflammation anywhere in the gastrointestinal tract. Crohn's disease can recur after surgery, whereas with ulcerative colitis, surgery is usually considered a definitive treatment for it. These are immune-mediated conditions, and the incidence of these conditions continues to climb, and this is a study that we recently did, and showing that each year, if you took 100,000 people, there would be 12 new cases of Crohn's disease, ulcerative colitis, and about 11 new cases of Crohn's disease each year in a population. And if you were to take the prevalence of the condition and add it together, it's about 0.5%. So in other words, 1 in 200 people, at least in Olmsted County, have inflammatory bowel disease. And if you were to extrapolate that to the U.S. population of 310 or whatever million it is now, it's basically 1.6 million people in the U.S. In all likelihood have ulcerative colitis and Crohn's disease. So these conditions are becoming more common because generally life expectancy with these conditions is normal or near normal, and therefore if the incidence rate is going up and you have a long life expectancy, then the prevalence rate is going to go up too. And here's the fascinating thing. When we used to talk about these conditions, and when I was in medical school, we talked about it basically being sort of a white person's disease. It was in Scandinavia, Northern Europe, the UK, Canada, the US. It was only in certain areas, and this just depicts the places where incidence and prevalence studies had been done in the 1950s, but when you fast forward to 50 years later, it has become a global disease. And so places like Korea, which didn't even see their first case of Crohn's disease until 1987, now they're seeing Crohn's disease all the time. Not as frequently as here, but it's becoming more common everywhere. The Middle East, if you go up to Mayo, up to my floor on a summer afternoon, half of the patients that I'm seeing with Crohn's disease are from Kuwait or United Arab Emirates. So it's become a global disease. It's not just confined to what we used to call the first world countries anymore. It's basically everywhere. And again, why that is, we don't know, but the hypothesis is that this is an intersection between having genetic susceptibility, maybe related to certain genes that regulate the immune system, perhaps an interaction with the mix of either bacteria or viruses or fungi in the gut, and then there's some environmental trigger that comes along and triggers this process where the way I simplistically think of it is like the inflammation doesn't know how to turn itself off, or it's that the immune system has lost the ability to tell between friend and foe, and so you have uncontrolled inflammation. And you're not expected to memorize this slide, but the point is that most of the genetic abnormalities that have been detected, and now there's over 190 different genes that have mutations associated with inflammatory bowel disease. Most of these genes have something to do with the way the immune system in the gut recognizes bacteria and how it handles inflammation. So that's why the hypothesis is that it's an immune-mediated disease, but we don't understand why only a very small subset of people with these genetic mutations actually get these conditions. So for any one of these given genetic mutations, only about 4% or 3% of those people actually go on to develop inflammatory bowel disease, and that's part of the mystery of what's going on. And again, the point here is that if you were to compare the intestinal microbiome of healthy individuals and those with Crohn's disease, the big difference is that you would see fewer species of organisms, and you would see a preponderance of what we call the Bacteroidetes and less of the Firmicutes. And so the Firmicutes are thought to be the good guys, and the Bacteroides are thought to be the bad guys, simplistically. And this whole science of understanding the microbiome is very costly and computer intensive, and we're just sort of scratching the surface. So this whole science of this is in its infancy, and I think in the future we'll see more and more therapies related to manipulating the microbiome. But right now we're having more success with therapies that work on the immune side of things, not so much on the bacteria side of things. So most of my talk is going to be about therapies that work on the immune side. If you were to sort of sketch an overview of what medical treatment for ulcerative colitis looks like, at the top, or the first-line agents, would be the 5-ASA agents, and these include drugs like mesalamine, valsalazide, sulfasalazine. They can be given either orally, or they can be given rectally, either in the form of a suppository or an enema. For patients who don't respond to those first-line agents, we'll often give a steroid as a second-line agent, as a rescue therapy, but that's a temporary thing. That's not a good maintenance therapy. And then for people who are not responding to that, we'll often go on to give them as a maintenance therapy, especially if they're, say, steroid dependent, either azathioprine or 6-MP or a biologic. And so with biologics, we're talking about the anti-TNF agents, or we're talking about the anti-integrins, and we'll get into that more later. Excuse me, let me go back. So again, I want to emphasize with steroids, they're a great short-term agent. This is a chart-based retrospective study we did of all the patients in Olmsted County who had ulcerative colitis. This was done in the pre-biologic era, where the first time they received steroids, the overall response rate was like 84% in the first 30 days. But then if you fast forwarded a year, many of those patients were either steroid dependent or had required surgery, and so the threshold of needing steroids generally signifies you really need to intensify therapy on your patient. You got to start thinking about stronger maintenance therapies, either an immune modulator or a biologic. Azathioprine and 6-MP are drugs that have been used as well, although their evidence base for success in patients with ulcerative colitis is not that great. You can see here the overall pooled odds ratio actually overlaps, the confidence intervals overlap 1, so technically not statistically significant. We use these drugs, they're good drugs, but I think there's emerging evidence over the last 5 to 10 years that A, they're not as efficacious as anti-TNFs, and B, a lot of the safety concerns that we have about anti-TNFs have probably been driven more by the fact that most of these patients have been on drugs like azathioprine and 6-MP, and we'll talk a little bit about that later. So the first biologic that was studied for ulcerative colitis was a drug called infliximab or Remicade. These were the pivotal trials showing that it worked, that a significant higher number of people compared to placebo were in clinical remission, both in the Act 1 and the Act 2 trials. And I think there's still a perception amongst many clinicians, myself included, that of all the biologics, that infliximab may be the one that's the most efficacious, at least for ulcerative colitis, and there's a perception that maybe with some of the subcutaneously administered biologics that maybe they didn't get the dose right when they did the trials. Nevertheless, they're reasonable drugs to use. They just may not be as efficacious. We also know that infliximab has the ability at the end of a year to decrease the need for colectomy, and so this was a spin-off of the ACT trial showing that the patients in the dashed line are the ones that were actually on placebo, and the patients in the solid lines were the ones that were on the drug, and you can see that the colectomy rates were significantly lower. There's also a perception that all of these biologics are protein-based drugs, and even though they might be humanized or, quote, fully human, unquote, they're not fully human. And the immune system figures this out, and you develop antibodies to the drug levels go to 0 or very low, the drug stops working. And so if you combine a biologic with an immunomodulator, you decrease the formation of antibodies to the drug, and you keep the drug levels higher, and the drug works better. And so this is an example of a study called the UC Success trial, and this was done in Canada and in Europe, and it showed that combining azathioprine and infliximab was better than taking infliximab alone, which was better than taking azathioprine alone. And so you'll hear people, if you really want to go for efficacy with these drugs, it's better to combine a biologic with an immunomodulator. Now that introduces a whole, the set of issues. Okay, well, what about the safety concerns? And we'll talk a little bit about that later. The other situation specific to ulcerative colitis is the patient who's really sick in the hospital with acute severe colitis. And what do you do for that patient if they're not responding to IV steroids? There were some centers in the US and in other parts of the world that were big fans of IV cyclosporin, but there were other people worried about IV cyclosporin because of side effects, including fatal infectious side effects. And so people have done trials like this one in France to compare infliximab to cyclosporin, and at the end of the day, it turned out that these were roughly equivalent. And so if you're more familiar with using infliximab in that acute setting, you probably should stick with infliximab. If you're up for trying cyclosporin, I think you wouldn't be faulted for doing it. There's no apparent benefit of one over the other, and a lot of it just has to do with familiarity with using these drugs. What about other anti-TNFs? These were the trials done to show that adalimumab was effective for ulcerative colitis. You'll notice that the overall remission rates here seem at least numerically lower than what was seen with infliximab. Now, you can't compare across trials. We do it all the time anyway. But at the end of the year, again, significantly better than placebo. And again, I think there's a perception that if you think about ulcerative colitis, you have a big inflamed organ, so you have a lot of inflammation to overcome. And then the other factor in ulcerative colitis you have is that you're losing protein through the feces, right? Because you have like a protein-losing colopathy with the inflammation. And so pharmacokinetically, that's another barrier that a protein-based drug, well, then that goes through the feces as well. This is why ulcerative colitis is such a hard disease to treat with an anti-TNF, and there's a perception that of all of the indications that anti-TNFs have, that the hardest ones to treat are inflammatory bowel disease, and ulcerative colitis is even harder than Crohn's disease because of this whole protein-losing colopathy problem. Golimumab is the third anti-TNF that's approved for ulcerative colitis in the United States, and this showed that it was significantly better than placebo for both induction of remission and maintenance of remission. I think the average GI doc probably uses a lot of the infliximab and adalimumab, and probably less of this. And same thing for Crohn's, maybe less of certolizumab, and I think just because of the timing of when they came out. The overall management of Crohn's disease is a little bit more streamlined than ulcerative colitis, and the big difference in this algorithm is that there are no 5 ASAs in this algorithm. So 5 ASAs have been shown in multiple meta-analyses, multiple Cochrane analyses, to be completely ineffective for the treatment of Crohn's disease, both for induction and for maintenance of remission. There are still a lot of people who put a lot of hope on 5 ASAs, and they use them for their Crohn's disease patients, but I just want to reemphasize the point that there's actually no shred of evidence that they actually work in Crohn's disease, and they're probably serving as a very expensive placebo most of the time. And so you try a course of prednisone or a course of budesonide. If that doesn't work, in other words, if they flare again, then they probably need to go on another drug. The old paradigm would be to go to an immunomodulator, and then if that didn't work, to go to an anti-TNF. If that didn't work, there was a drug called natalizumab or Tisabri, which we use very, very rarely in Crohn's disease. And depending on which of these drugs the patient responded to, then they were given maintenance treatment with one of these drugs going forward. So 5 ASAs, again, to reemphasize, they're widely used in the United States still on the basis of a trial that was done 20 years ago, but then subsequent trials, which were suppressed by the drug sponsor for many years, were negative, and that's why the drug was never approved for Crohn's disease. And yet, because of that sort of high-profile paper 20 years ago, they were widely used for Crohn's disease. But there's absolutely no signal for efficacy in Crohn's disease, so I would recommend to not use them. Similar to what I had shown you before for ulcerative colitis, in Crohn's disease, steroids are very effective in the short term, but over the long term, most of these patients end up being either steroid dependent or require surgery, and there's very few patients who actually have a prolonged clinical response to corticosteroids. And so if your patients with Crohn's disease need steroids, that's a signal that they need to be on a stronger maintenance therapy in general. Budesonide is a reasonable option. Budesonide is a highly potent steroid with high first-pass hepatic metabolism. It can be given in a delayed-release pill, both an ileal release for Crohn's disease and a colonic release for ulcerative colitis. They're two different formulations. Again, a good induction therapy with fewer side effects, but not a good maintenance therapy. So the longest I'll use budesonide is maybe 5 or 6 months, but if the patient can't get off of the budesonide, is flaring afterwards, it's time to escalate to a stronger maintenance therapy. So azathioprine, historically, step-up therapy meant that after steroids you went to azathioprine or 6-MP. More updated meta-analyses are suggesting that maybe this doesn't work as well as we thought, and you can see that the pooled odds ratio here, the confidence intervals actually overlap 1, so technically not statistically significant. There's probably a trend, and we all have patients with milder forms of Crohn's disease who actually do respond to thiopurine, so I think they can be used selectively, but I think it's sort of talking to the patient about the efficacy versus the risks, and sometimes it might make more sense to go with an alternate agent. Don't get me wrong, we still use these drugs, they're good drugs, but I think we may have better drugs. Methotrexate might be an option for patients who don't tolerate azathioprine or 6-MP, and we can give this either orally at lower doses, or if you want to give higher doses, you probably should give it subcutaneously. And there is a perception that maybe there's less lymphoma issues with methotrexate than there are with azathioprine and 6-MP. And so some people will selectively use methotrexate if they have to give combination therapy. So the anti-TNF biologics, we talked about some of this a little bit already with ulcerative colitis, infliximab for Crohn's disease, certolizumab, which is actually an antibody fragment attached to a large polyethylene glycol molecule, and then adalimumab, which is considered practically 100% human. It turns out, though, that that whole issue about human versus chimeric, they all form antibodies, so you're not out of the woods in terms of antibody formation if you use adalimumab compared to the other ones. So there are a lot of induction trials out there. The outlier was that first Targan trial with infliximab. Generally, the remission rates at week 4 are in the 20 to 30% range. And then if you follow people out 6 months, if you multiply, because the way these trials are designed, it's only the patients who responded to the initial that then get randomized. So you have to do a little multiplication to get the true net remission effect. But generally, you're talking about a 20 to 30% net remission at 6 months with these drugs. And this is the challenge, because these are our most efficacious drugs for Crohn's disease, and yet even there, you were talking about 30% effectiveness rate. So these are challenging diseases to treat. Now, that's clinical trial world where you can't alter the doses. In real life, we might dose escalate, we might combine with another drug, and we can probably drive the remission rates higher, but this is what was reported in the clinical trials. We also know that these drugs have the ability to actually heal ulcerations, and if you think about it, it's sort of common sense. If you can heal the inflammation, then you can probably prevent the long-term intestinal complications, because what drives surgery in Crohn's disease is not the inflammation itself, it's the formation of strictures, the formations of fistulas and abscesses, and it's that sort of low-grade morbidity that is associated with repeated surgeries that actually results in decrease in quality of life and what we call intestinal disability. So things like bile salt diarrhea, small bowel bacterial overgrowth, B12 deficiency, gallstones, kidney stones, all of that is driven by the need for surgery. And so you have to prevent the surgery up front, you got to prevent the intestinal complications, and to do that, you have to heal the mucosa. And so in general, it's the biologics that tend to have the highest mucosal healing rates in Crohn's disease. And I'm showing you this slide not because I want to focus on natalizumab, which we don't use much anymore, but this interaction between the lymphocyte, which expresses these things called integrins, and the endothelial cell. And the endothelial cell expresses adhesion molecules, and it's that interaction between the integrin and the adhesion molecule that allows the white cell. It's sort of like a zip code messaging system. The white cell knows when it can exit the blood vessel and go into the tissue and cause inflammation. And it turns out that some of these adhesion molecules are gut specific. So in particular, this MADCAM1, this is found only in the vasculature of the gut, essentially. And so it's a relatively gut-selective target. And so it turns out that this alpha-4 beta-7 integrin, that's what this new drug called vedolizumab targets. So by targeting alpha-4 beta-7, you're sort of targeting indirectly MADCAM, which means you have a biologic that's sort of gut-specific rather than systemic. And that's why I think you've seen an uptake over the last 2 years in the use of vedolizumab as a treatment for inflammatory bowel disease. So risk stratification. I think one of the big issues is identifying who are the high-risk patients. And when I say high risk, who are the patients most likely to develop intestinal complications or require surgery? And those are the patients that you should probably recognize up front and treat more aggressively. So this is an example of a study we did in Olmsted County where we looked at about 300 Crohn's disease patients. We followed them through their medical records to see what were the risk factors that were associated with time to first surgery. And the things that came out that were positive were male gender, small bowel involvement relative to colon involvement, ileocolonic relative to colon, upper gut relative to colon, cigarette smoking, having penetrating disease behavior, which means you're having an internal fistula or an abscess or a phlegmon, or need for early steroids. So if you have a patient who's meeting several of these criteria, you can make a good argument for doing what we call top-down therapy rather than step-up therapy. So we're seeing more and more GIs who are actually saying, okay, this is a high-risk patient, a young male with ileal disease who has a sinus tract. Treat them up front with a biologic rather than putting them on Pentasa and then steroids, and then waiting till they have multiple intestinal complications and then using anti-TNFs before, after it's already too late. And so there's been this sort of gradual shift that's taken place. This is another example. In this study, we weren't looking at time to first surgery. We're looking at time to first intestinal complication, and we found the same thing. It's location, location, location is what drives the need for surgery, because the need for surgery is driven by this, the intestinal complication. So a patient with ileal involvement, I would submit to you as a patient who's a high-risk patient. And so those are the patients who need to be treated more aggressively medically to prevent the complications, to prevent the surgery. And so we're seeing this, again, to summarize, the young age patient, the ileal extent or ileocolonic descent, fistulizing disease at diagnosis, early need for steroids, that's a patient who you should treat much more aggressively than the older onset patient with colonic disease and just aphthous ulcers in the colon. Yeah, well, maybe you can get away with a 5-ASA in that patient, but as soon as those ulcers start getting deep, they need more systemic therapy. Again, I kind of alluded to this top-down versus step-up. This is an old study now, but it showed that if you treated patients up front with infliximab and azathioprine rather than doing the step-up approach, you had higher rates of steroid-free remission through week 52. Now, at that point, the results converged, but the way they did this study was probably incorrect. They gave the infliximab up front, and they didn't give maintenance infliximab. So this was just episodic infliximab after the first 3 doses. So if they had done it the right way, I suspect the results would have been different. The other thing we've realized is, again, I sort of alluded to this with UC success, that combination therapy with infliximab and azathioprine is better than just infliximab or azathioprine alone. And I use the data from this all the time in the office with patients to convince them why they need to switch from, say, azathioprine, which is easy to take because it's a pill, compared to infliximab or adalimumab, which is an infusion or an injection. But clearly more efficacy with the biologics. We know that the biologics reduce hospitalizations, they reduce surgeries, that's been shown. And then the other big switch in our sort of management of these patients is that we're trying to make treatment decisions more objectively, not based on symptoms alone. This is an old study, but it still holds true. There's a complete lack of correlation between the CDAI score, which is a symptom-based index, with the CDEIS score, which is an endoscopy-based index. The R value is low, the P value is non-significant. So there's a group of patients who have bile salt diarrhea and bacterial overgrowth who have a lot of GI symptoms and have absolutely no inflammation. And then on the other side, you have these sort of stoic individuals who say, yeah, I'm fine, and then you look and they have raging inflammation. And we have to, in order to make our drugs more effective, we have to assess them objectively so we know what's going on and get the treatment aligned with the need. Because again, symptoms could be due to all these other things, not just active Crohn's disease. Just an example, bacterial overgrowth. This was a German study where they took consecutive patients with Crohn's disease, did breath hydrogen tests on them, and 25% of them had objective criteria for small bowel bacterial overgrowth. And if you think about it, they've lost the ileocecal valve, they've got a stricture, they might have a blind loop, and now our surgeons are doing all these side-to-side anastomoses, so there's more blind loops. So these patients are at unusually high risk to develop bacterial overgrowth. And so you don't want to treat a patient that has just bacterial overgrowth with a biologic if they don't need the biologic. And so you have to keep these things in the back of your minds. And this is where it all comes together, because here you take the patients who at baseline in the SONIC trial actually had objective inflammation, and then you see huge differences in the treatment arms. Whereas if you took the patients who had no baseline, so they had an ileocolonoscopy, they had no baseline inflammation, well, it didn't matter what you gave them because it wasn't inflammation that was causing their symptoms. And so this is the issue, is that now we have these better treatments and we have better ways to assess our patients. And when you line them up, that's when you hit the home run, 60% steroid-free remission rates. And that's what we need to be doing on a regular basis with our patient, is marrying up the patients with inflammation, actual inflammation, with the most effective therapies. So again, a paradigm shift from the old to the new, where we used to make these treatment decisions based on symptoms, and we want to make the treatment decisions based on objective evidence of inflammation. The issue is, I'm going to skip this in the interest of time, the issue is, what do you measure objectively? Well, in a patient that has colonic disease or maybe very distal small bowel disease, you can probably get away with a colonoscopy to measure inflammation objectively. But in a patient who has more proximal small bowel disease, you're going to miss it. And so you may need to use something like an enterography. In an older patient, you can get away with a CT enterography. In a younger patient, you don't want to do that repeatedly because of radiation risks. And so you might want to use MR enterography in those patients with more small bowel involvement. But there's this emerging concept of treat to target. So if the target is objective inflammation, it's going to be endoscopic inflammation in the colonic patients. It's going to be radiographic inflammation in the small bowel patients. But you could come up with an algorithm where you assess the patient, you have the baseline, you start it's kind of like oncology. They have the marker, they give the chemotherapy, they repeat the test to see as the marker shrunk. Well, we've got to do the same thing in GI. So we have our baseline assessment, we introduce the biologic, and then somewhere 3 to 6 months later, you repeat the tests and see, okay, have you made any progress? If you haven't made any progress, then you need to switch things around. You either need to increase the dose of the biologic or combine it with an immunomodulator. And so this is sort of the shift, I think, in the treatment paradigm, where you assess the patient after you've introduced the new therapy. If you're making progress, great, maybe come back in a year or reassess. If you're not making progress, then you need to change something up. And so this is sort of what treat to target would look like. Challenges that mucosal healing, right now when people talk about mucosal healing, they're talking about it as if it's an all or none phenomenon, and there's probably some increment, like, okay, so let's say they can decrease inflammation by 50%. Well, maybe it's not fully healed, but it's 50% improved. That might be good enough, and we've got to work that out in our studies and our trials. What's the minimum amount of endoscopic improvement that will lead to improvement in clinical outcomes? So I want to talk a little bit here about therapeutic drug monitoring. So we have two types of therapeutic drug monitoring, one for drugs like azathioprine and 6-MP, and then another type for the biologic. So with azathioprine and 6-MP, it has a very complicated metabolism, and we know that there's variations in how people metabolize this. The one main enzyme is called TPMT, and about 90% of people have normal metabolism. 10% of people have intermediate metabolism, and then 1 in 300 people have virtually no metabolism. So if you give these people azathioprine a normal dose, they're going to get really sick because they're going to end up in the hospital with neutropenic fever. These folks here get a half a dose, and these folks here get a full dose. So usually before we start azathioprine, we get this enzyme level called TPMT to see where we should start. And it's been shown also that if you get metabolite testing and you use a 6-TGN level of 238 or higher, you're much more likely to be in remission than if your metabolite level is below 238. And so if you're above that 238, you had a 62% chance of being in remission, and if you were below 238, only a 36% chance. And so in a patient where you're really trying to push the dose of azathioprine, you should use these metabolite levels to help guide your therapy. If you're just using the azathioprine to combine with the anti-TNF, where you're just trying to prevent antibodies, you probably don't have to be as aggressive in pushing the dose of azathioprine, and even a half dose is probably going to be enough to suppress antibodies and improve outcomes. So the other type of drug level testing we have is for biologics, and we have this clinically available for infliximab and adalimumab. There's a new company now that has levels for vedolizumab and also certolizumab. So now we have 4 different biologics that we use in IBD that we have drug levels for. And it's been shown that if you have a detectable trough level, and a trough means you're checking the level right before they're due for their next infusion for infliximab. So if you had detectable trough, you were much more likely to be in remission, much more likely to have a low CRP, much more likely to have endoscopic improvement, and much more likely to be in endoscopic remission, which means mucosal healing. And similarly, with adalimumab, if you have detectable trough, you are much more likely to be in clinical response than if you had an undetectable trough. And so you can use the information from these trough levels combined with antibody levels to make decisions, okay, do I increase the dose of the drug, or is it time to switch to a different drug because I've already developed antibodies to it. The pharmacology behind these biologics are very complicated. Being on an immunomodulator decreases drug clearance, which increases the level of the drug, but all these other things increase drug clearance and decrease the levels of the drug. So anti-drug antibodies, having hypoalbuminemia, having a high CRP, having high TNF levels, having a high BMI, and if you think about, especially if you're on a fixed dose injection like adalimumab or certolizumab or golimumab, if you have a big BMI, you have a higher volume of distribution and you're going to have a lower drug level. Whereas if you have a weight-based biologic like infliximab, where you're dosing it by milligrams per kilogram, you probably have a higher chance of success in a high BMI individual. And so people, we did this study at Mayo a number of years ago, and if you had a positive HACA, which is an antibody to infliximab, then, and you had an undetectable drug level, it was time to switch to a different drug. If you had a low infliximab concentration, then it made more sense to increase the dose of infliximab. You had a higher chance of success. The problem is if you have a therapeutic level and you have active disease on colonoscopy or enterography, then that's telling you that for whatever reason that patient is not, they've sort of bypassed infliximab somehow, their inflammation has, and it's time to switch to a totally different drug. Other people are trying to use these drug levels more proactively, so like at week 14, so right before they're due for their 4th dose of infliximab, checking the trough level and then optimizing it in advance of any type of clinical loss of response. And in this small study from Boston, this suggested that being proactive about checking it resulted in staying on infliximab for a much longer period of time than if you were just sort of reacting rather than being proactive. In some cases, if a patient has low levels of antibodies to the drug, you could probably overcome that by adding in an immunomodulator. There have been case reports of this in the literature, and here are some cases from, this was an Israeli study, but that's not always going to work, especially if they have really, really high levels of antibody, but something to think about in some of your patients. So vedolizumab technically isn't a new therapy anymore. This has been around for 2 years, but this is that alpha-4 beta-7 integrin antibody I was talking about earlier, and this is the data in ulcerative colitis, induction therapy. This was the data in Crohn's disease, so both doses of vedolizumab were better than placebo. So this is a drug that's legitimate to use. It has probably a more favorable safety profile than anti-TNFs do. And so this is a safer drug. It's a gut-selective biologic, and so this could be considered in some of your patients with ulcerative colitis. In Crohn's disease, it works too, but maybe not as well as it works in ulcerative colitis, and there's a perception that in a Crohn's patient, maybe your first-line biologic should be an anti-TNF, whereas in ulcerative colitis, you could make a good argument to use vedolizumab as a first-line biologic agent. There's also this drug that will be getting approved for Crohn's disease probably this fall, and it's called ustekinumab, and some of you may know this as Stelara, which is a psoriasis medication. And so ustekinumab blocks IL-12 and IL-23, and it's been developed for Crohn's disease. This is an example of one of the trials they did, and it showed that it was effective in the short term compared to placebo. These were in patients who had not been previously on an anti-TNF, and then it was studied in patients who had already been exposed to an anti-TNF and were failing, and it worked in that population as well. They then did a maintenance trial and showed that it worked over the course of a year. So the FDA has to make a decision on this drug by the end of September or beginning of October. So by the end of the year, it'll be approved for Crohn's disease. We're already using it off-label in many of our patients who have failed multiple drugs and having some success with it. The interesting difference between the psoriasis dosing is that for IBD, the initial dose studied was an IV loading dose. So the initial dose will be an IV loading dose, and then the subsequent doses will be subcutaneous. So it'll be a little bit different than the psoriasis dosing. So we have, again, we have 4 different anti-TNFs for IBD. We have vedolizumab, which is that anti-integrin I just showed you, and then we're going to have ustekinumab. There's also that other one, natalizumab, but we don't really use that anymore. And the reason we don't use that anymore is that that can cause PML, which is a serious neurologic condition. And so we're less likely to use it. Some of you may have heard about this other drug in the pipeline. This is way earlier in the pipeline. This is an oral agent called mongersen. And this is an oligonucleotide that blocks something called SMAD7. And in this interesting trial, so in this trial, the patients received 2 weeks of this oral drug, 2 weeks, and then 10 weeks after they stopped taking the drug, they were seeing remission rates as high as 50 to 60%. So it's either going to be really, really big or it's going to be a big blow up. We don't know. We have to see. We don't have any endoscopic data on this drug, but it could be a really interesting drug, and it may change our treatment paradigm. But by the time this drug gets out, it's like 4 years out from being fully developed. So it's not going to hit the shelves for a long time. Another drug that might be coming out in the next year or 2 for ulcerative colitis is called tofacitinib. And some of you may already know this because it's approved for rheumatoid arthritis. And this is a small molecule, and it blocks an enzyme called Janus kinase. And this is at the highest dose, 10 milligrams BID, it was effective, and it was recently shown at our big meeting in San Diego in May. The 2 induction trials were positive. We're waiting for the results of the maintenance trial. And I think this is telling me that it's time to end. So I think I'm going to wrap up here and just say, again, these are chronic inflammatory conditions, high morbidity. 5-ASA drugs are first-line therapy for ulcerative colitis, but not for Crohn's disease. Steroids are effective for the short term, but they shouldn't be used as maintenance therapy. Azathioprine, 6-MP, methotrexate are reasonable steroid-sparing agents. The anti-TNF drugs are effective for inducing and maintaining response and remission. They can reduce the need for hospitalizations and surgeries. Natalizumab's an option, but we don't use it much anymore because of PML. We're switching to a paradigm where we're using objective markers of inflammation to assess our patients and make treatment decisions. And then this treat-to-target concept is also evolving, and use drug monitoring when available. And I'll stop there. Thank you. Happy to take any questions.
I was aware that the American Gastroenterological Association was doing an alternative payment model using inflammatory bowel disease, and I was really struck by the results. They actually showed that when they had patients engaged with their gastroenterologist, that they had much better results, much fewer hospitalizations, many fewer complications. So do you think that alternative payment model is something that might be helpful to get more patients engaged with their gastroenterologists?
Yeah, I mean, I think part of the phenomenon that occurs is that I mean, these are diseases of a lifetime, but it's like watching a car accident in very, very slow motion. So there are going to be time periods, and again, they're characterized by natural remissions and relapses. There are time periods where it's easy for the patient and for the patient's doctor to fool themselves and think that the patient is stable, that nothing is happening, and I can go off of my medication, and I don't need to see my doctor, and I beat it this time. I really beat it this time. And I can't tell you how many times I see that. And then that all blows up in their face when they develop a major intestinal complication. So yes, I think any way we can keep the patient engaged and remind them to adhere to their medication regimen, anything that can be done to streamline the other observation I've made is whenever an employee that works for a small business has to go through an insurance company change about once every 2 years, literally once every 2 years, because they're always bidding out to get the cheaper insurance plan. Every time that insurance plan change occurs, there's a hiccup in getting their biologic refilled. And so anything that can just smooth that process of the things that we don't even think about. And my own bias is that for any given outcome in IBD, it always looks better in a single payer system because of this reason. And I actually can show you data that for any given outcome, like time to surgery, time to whatever, it's going to look better in a single payer system than it will in our system, because we have all these people that are disincentivized to be engaged and stay on their therapies. And so anything we can do to improve that, I think, would be a good thing.
Yeah, is there an advantage, cost advantage, or an advantage in regards to side effect profile for using the vedolizumab versus a TNF blocker?
One of the problems is it's slightly more costly than being on infliximab infusions, and in general, third-party payers don't like infusions because of all the extra costs associated with the infusions. They prefer the sub-Qs for that reason. So no, there's not enough compelling safety data yet, but the big difference is vedolizumab does not have black box warnings on infection, does not have black box warnings on lymphoma or any malignancy for that matter. And so the problem will be, will you be able to show over a long period of time that you're going to have cost savings because you're preventing those? So that's the challenge, is going to be that window, you probably need a 5-year or 10-year window to prove that, but the third-party payer only looks at 2 years out. Like they don't care about 5 years or 10 years. If you can save me money in 2 years, I'll listen to you, but if not, I'm not going to listen to you. So that's one of their big challenges. And they're getting tiered. I think literally in ulcerative colitis, they should be in front of anti-TNFs, but the third-party payers are tiering them behind the TNFs for a variety of reasons, but some of it has to do with the cost, I think.
Dr. Loftus, prevalence in first world countries, is that diet or exposure to, or lack of exposure to intestinal infections?
I think it's a combination of that. I think it's probably the Western. So it's interesting. There was a lot of data at DDW about diet, and there were actually interesting associations between ingestion of dairy products and intestinal inflammation. So I think it's the Western diet that's high in dairy, high in sugar, high in red meat. Those things are probably contributing, and also the hygiene hypothesis in these areas of Asia, for example. There's a huge, burgeoning middle class. So that these kids are growing up under much improved sanitary conditions, and so they're not exposed to these antigens. Maybe it's like lack of helminthic infections or other infections. There have been studies showing that H. pylori is protective against the development of inflammatory bowel disease, and therefore if you remove H. pylori, you might be increasing the risk. So I think there are all these unintended consequences of things that might be contributing to the increased risk of IBD. But I don't know if we can fundamentally pin it down to one thing. I suspect it's multifactorial.
So the causative factors probably had some protective quality at an earlier stage.
Yeah, so there's this interesting data with NOD2 mutations, and there's this interesting speculation that so NOD2 is the genetic mutation that has the highest association with Crohn's disease. Well, there's some, and I can't remember exactly how they figured this out, but having those NOD2 mutations probably reduced mortality when you had tuberculosis. In other words, you were less likely to die of tuberculosis when you had that NOD2. So there had to have been some selective pressure to conserve the mutation. And so it probably has something to do around infections, surviving infections. But that's like one example. I don't know why, for the other 189 mutations, I don't have the story on that.
I'm a neurologist, and we still use natalizumab Tysabri, but we only give it to people that are JC virus negative, and we periodically test them for JC virus. Is there any thought about doing that, or are there other drugs too that might also be a risk for PML?
No, as part of the MAPS program in Crohn's disease, you're sort of mandated to get JC virus antibodies and discuss that with the patient. So I still have a few patients still on Tisabri. One patient going on 8 years now. She started when it came out for the Crohn's indication, and I check her JC virus serology every 6 months, and as long as it's negative, we continue. But I think the dynamic is different because in Crohn's disease, you have a group of young patients with no other comorbidities. They have no neurologic symptoms to speak of, so when they hear a neurologic side effect, boom, their eyes glaze over, and even when they're JC virus antibody negative, you still can't convince them to go on natalizumab, where I think in MS, I already have a neurologic symptom, and maybe this might make it better. And so I think it's a different dynamic, but I found that that was the most challenging drug to convince patients to go on, much more so than, say, combination therapy with infliximab and azathioprine. And so I think natalizumab is just never going to take hold in Crohn's disease for that reason. Okay, well, thanks a lot.